there are reasonable things that we all can do to indeed give patients the care that they desperately need and do it in a way that's safe to us.
So you're seeing patients, you're having to see them.
We're back for, this is the end of our first week back.
Okay.
Providing what I consider essential care that up to 6 weeks ago was apparently considered non-essential care because they just quote unquote emergencies, but I feel pretty strongly that eliminating inflammation in people's mouths is an essential service that we provide.
I love that, and I think that's true. And I think essential elective procedures are in the eye of hopefully the healthcare professional. That's you, the doctor, right?
Amen.
So,
yeah, I've worked with a couple different states on developing backdoor guidelines, and in the few experiences I've had, they have basically medical people with no dental knowledge working on things.
wow.
And the big difference in dentistry compared to medicine is, yeah, dentistry has the potential to like generate aerosols, et cetera, but we also have the ability to control them.
Right. Oh, you know what? That's what I wanted to ask you about. Am I wrong when your white paper that was just published last weekend, right?
Correct.
Gives me hope that we don't have to change the whole world. We can control aerosols with some existing technologies that are out there, and there's some data that backs that up. That's kind of what how would you summarize your recent?
Bottom line to the whole thing is, we already have the solution in dentistry. We've had the solution in dentistry. We didn't follow it. We're not proposing anything groundbreaking. What we're saying is do the stuff we really should have been doing all along. There has been evidence since 2004, even earlier than that. We know how to control aerosols. We know how to protect ourselves against aerosols. If, in fact, we can get everything in line to minimize all the potential risks to the greatest degree possible, that certainly ends up where the risk-benefit analysis is on the side of absolutely providing care that people need. They need our service.
Right. And it doesn't take a $3,000 or $30,000 worth of negative pressure devices and HEPA filters necessarily to do that. There might be a solution that is economical and readily available and one that we're familiar with.
Yeah, absolutely. The thing that people don't understand is, like, we have devices that have the potential to generate aerosols, and all of the research about dentistry is the #1 most dangerous profession. Aerosols go in the air, they last for 30 days or whatever the latest number is. That's if they're not controlled.
Right.
If they're controlled, it's not an issue. The difference in medicine is, like, when they take a tube out of somebody, they don't have the type of vacuum system that we have in dentistry. They don't know where it's going to go. When they take the tube out and fling it out of the patient, that can go anywhere. We know exactly where the aerosol is. We have the ability to capture it before it escapes out into the other area. And then add on to that the layers of, we can minimize the chance that there's a patient that's COVID positive in this instance. We can minimize the chance that anything is going to land on us. I mean, we're in fabulous shape if we just follow the recommendations that we really had. No, I don't think we need, nor is it reasonable or possible to do $500,000 renovations on every office to meet some hypothetical standard.
And just so people understand who might not have heard your name before, I probably should have allowed you to introduce yourself and give a little bit of a CV so people realize that you've written textbooks on this and you know a little bit about aerosols. You're doing webinars on aerosols all the time these days. You have the very first Cavitron, is that correct?
That is correct, yes.
That is the coolest thing. That should be at a museum.
I'm a periodontist, private practice. I'm also involved in research and do quite a bit of continuing education. And my thing has always been, number one, it doesn't have to be as confusing as everyone thinks it is. Secondly, there's so much misinformation that's out there, and even the reading of the literature is oftentimes read with a bias and presented with a bias. So I've tried really hard to take what's out there, take the true evidence-based approach where you actually determine the value of the research, what you can actually say for sure from it, package it in a way that makes sense, and use clinical judgment, which is part of the evidence-based approach, to determine what's the most reasonable thing to do. Now, when you apply all of that to the chairside situation, there are reasonable things that we all can do to indeed give patients the care that they desperately need and do it in a way that's safe to us. It's possible.
And you've seen lots of data that shows a standard high volume evacuation tip used properly can eliminate 90 to 98% of aerosol.
And here's the deal with the whole thing. And, you know, it's almost interesting. In one regard, it's fascinating. On the other side of the coin, it's almost scary that no one apparently in dentistry has ever paid attention to this. It's simple fluid dynamics, which I myself just learned about 6 weeks ago when I was thinking, how in the heck am I going to go back into the office? The amount of capture that's going to occur is going to depend on the strength of the vacuum, if you will, from your vacuum system, but also the diameter of what the capture device is. So everyone has the misconception that HVE, you can hook anything up to HVE. Well, the HVE line is hooked up to the exact same vacuum that the saliva ejector is hooked up to. They're both pulling the exact same vacuum force. What makes one have a greater velocity of flow is the diameter of it. All of the research, the only research that's available, and there's decent research, was done looking at 8+ millimeter large bore tube hooked up to the HVE.
About that big around, right?
That's the diameter, and the typical disposable high evacuation suction tip is what's been studied, what's been shown to reduce 93 to 98% of the aerosols. Now, there are a bunch of aftermarket products that all will say we reduce aerosols 98% because we hook into the HVE, and that may or may not be true. It really depends on the geometry.
That you're saying that there's some marketing by those people. They're using that 98 number, like they're claiming it like it belongs to them, when really it may belong to the data that might not.
There's nothing magical in the HVE. It's what you put into the HVE and the diameter of what's capturing it. So you could even have a device that has a whole bunch of little holes in it that you can prop in the patient's mouth, and the area of all those holes might equal the area of an 8 millimeter round bore, but it won't capture the same. It's a matter of diameter and the suction are the two factors that go into it. Well, we can't change the suction, although, you know, another thing I did back to work is I absolutely had a tech come out to make sure that my vacuum system was not only adequate in size for my office, but was functioning properly too.
I got a couple of questions. The first one is, what do you use? What do you use? I suppose it depends on the procedure you're doing, but do you have something that you've been using like today?
I just got done yesterday and today. I spent all day doing ultrasonic debridement, part during surgery, part non-surgical. I placed a couple of implants and had the implant motor with irrigation on it. I then also had to extract a pretty nasty maxillary molar that I ended up having to do a little bit of work on the bone to free it up to get it removed. I had to use a high-speed drill doing that. I use a disposable high vacuum tube. The white ones that come 500 in a bag for a nickel. Here they
Yeah.
are.
Right.
But even that, they have ones that have screens on them. They have ones that are shaped differently.
They have slots. They're slotted or not
You don't want
slotted.
that. You need at least 8 millimeter round hole. And actually, that's what's been studied. That's what we know for sure works.
Can you clarify? I think I stepped on your. I think you said not slotted is better, correct?
That's correct, because and a great analogy is in reverse is your shower. If you turn the water on in your shower and you measure how much water fills up after a minute, and then you turn the water off, you take the shower head off, you turn the water on, and you measure after a minute. Without the shower head on, there's a ton more water comes out because there's nothing impeding its flow. Well, it's the same thing with airflow dynamics in reverse. So if indeed you have a large tube that has the little screens, and sometimes people manufacture them like that to keep the cheek from going into it or keep tissue out of it, that is going to impede the flow, and it's not going to have as much of a collective force, if you will, as an open one.
I'm assuming there's some technique involved in the distance that it has to be. Is there training involved? How
there's not training, but you obviously want to get whatever capture device you have, you want to get it as close to the operative site as possible. The intent is to capture the aerosol before it spreads and stays in the air and all that other stuff. But for instance, with ultrasonic instrumentation, there's a little bit of a learning curve because you want it as close as possible, but not too close.
Right.
Because with ultrasonic device, you need the water flow to generate not only the cavitation force, which is a really important part of it working properly, but to dissipate the heat that's generated from a patient comfort standpoint. Now, what that really opens the door up to is a discussion on there's a whole plethora of these woodwork devices, I call them, that are coming out of the woodwork.
Oh my gosh.
Capture devices with a big long elephant tube with a variety of sizes of things at the end of it, which may or may not work. They've never been tested. We don't know. I know from common sense that, number one, whatever it's capturing it into has to be sealed, has to be well sealed. Otherwise, it's just blowing it back in the room. Now, that doesn't happen with your vacuum system that's built in the office, because the aerosol then becomes a liquid and goes into the sewer system.
Right.
The second thing is, with those big elephant trunks, there is no way that I'm aware of to clean them.
Right.
And once again, with basic fluid dynamics, when you turn one of those standalone devices on, there's a momentary change in turbulence in the air where a puff of that has the potential coming out. So if you have that whole tube filled with the pathogens from the 300 patients that have been in there so far, number one, that could blow it back in the room. Secondly, you can't place that as close as you can the large bore suction, the HVE.
Got it.
You can't place those standalone things. So if it's further back, the aerosol has a chance to spread out before it's attracted into that. And then based on the flow, the stuff that goes along the side is ultimately has the potential, at least, to go right past your face while you're sitting there. Now, there are a lot of factors that go into how that's going to happen: temperature, humidity, what airflow you have in your operatory. It has to be an individualized solution, and there's no doubt that we need improved air quality management in dentistry. However, man, to go out and start buying these $3,000 things without even knowing whether they work, when there's things we can do that we know work.
And speaking of the ultrasonic scalers for hygiene, it sounds like we can get back to doing hygiene, but can a dental hygienist use a Cavitron and do a high-speed ergonomically herself, two-handed?
Yeah, well, there's no question about it that providing effective periodontal therapy by yourself is difficult. There's no question about that.
Right.
Now, there are a couple of things that are available to make that easier. There's one company has a device that turns the HVE tubing into kind of a 90-degree. It makes a pistol grip, which makes it a little bit easier to hold that ergonomically with the ultrasonic in the other hand.
Is that the Hogger product?
Yeah, that's correct.
Hogger Worldwide, okay.
Yeah, they make a pistol grip thing that has helped a lot of hygienists working alone. Dentsply has a product called PureVac, which is it meets all the criteria of having 8+ millimeter opening. And it also is ergonomically shaped to make things a little bit easier. It has a mirror built into it, et cetera, et cetera. But once again, and it also has, it has been tested in terms of delivering the airflow volume that we need. But keep in mind, I'm pride myself on being a staunchly independent believer in the science rather than what the commercial tells me. And I've really tried to resist the Facebook evidence that's out there. I'm certainly not saying go buy one. What I'm saying is do your homework. Before you buy anything, we know an 8 millimeter plus diameter large bore captures 98% of it.
Honestly, that gives me hope. It gives a lot of people hope, I think. And that we don't have to figure out which one of these new expensive products we have to buy or what kind of remodeling we have to do or.
Well, and add to that if in fact we up our game with PPE, and we're all doing that, many of us have used ultrasonic simply with a saliva ejector, and that can't happen anymore. Many of us have done it without face shields. That can't happen. Pre-procedural rinsing, screening of the patient, we're putting a lot of things in our favor to reduce the likelihood that there's going to be SARS-CoV-2 virus floating around the operatory. Now, with my comments about being a scientist, I've resisted really entertaining some of the anecdotal stuff, but I think it's worth mentioning. Number one, the virus didn't come to the United States the day I closed my office. It's here probably longer than we thought. So in high density cities, for instance, in New York City, which has been hit very hard with this, clearly there were people that were COVID positive going into dental offices in the month of December and January and into February. There has been pretty high level tracing done. I'm aware of no report where there's entire offices, dental offices, where the staff became infected with SARS-CoV. I'm not aware of any instance where there's a great propensity of dentists that have tested positive.
Or dental healthcare workers in general. Have you? I haven't seen it.
Now,
Right.
if in fact, look at what we've learned so far in a short period of time with nursing homes. We know that's a dangerous place to be. That absolutely would have come out by now. And then if you add to that, and again, I say this with a little hesitation because I certainly appreciate that this isn't pure science, but even from an anecdotal standpoint, there's been 9 zillion dental procedures performed with less than adequate PPE, with less than adequate control. And there's never been a documented case of an outbreak of stuff.
That
also gives me
the experts on that, yeah.
No, and I believe me, we need to up our game. I'm embarrassed that we haven't done a better job. I'm embarrassed in dentistry that, I took a photograph about 4 or 5, well, probably 6 or 7 weeks ago, because it was right before we closed, to use in a lecture. And when I set the photograph up, I was very cautious to make sure everything looked clean and looked presentable.
Right.
Everything out backward. I'm embarrassed at the way I look. I don't have my arms covered. I have the mask kind of flimsily hanging there.
They're going to use this as how not to do it at the next lecture.
So if I've survived in practice up to this point, and have done a respectable, but certainly not a thorough job of protection. And if I up my protective game, I'm totally comfortable going in and performing any procedure, and I've done it.
Nice. Well, thank you. It's really comfort. So there's some comfort there in a scary world where there's a lot of people using fear to make headlines and sell products, and the news is, all negative by and large. So it's nice that there's research and there's data that shows that there's data that shows that, there's signs of hope, I think is what I'm trying to say.
I really think that's a reasonable characterization. Yes, absolutely. I would love to be able to use a N95 for every patient. I would love that. You can't. They're not available. At this point in time, they're not readily available. I would love to have it fit tested, the ones I have. Those pathways aren't well oiled between the fit testers and dentistry.
Oh my goodness.
If you want to test it properly, the mask is destroyed in the quantitative test. The mask itself has to be destroyed during the test. And that's the most accurate way to fit test, is rather than a qualitative test, to do the quantitative test. I can't spare one N95 mask at this point for the testing. So I do the best I can. If I don't have an N95, as long as I'm capturing the aerosol, I have patients who have been screened, temperature screening, question screening, they pre-rinse, I have adequate PPE, I am very cautious in my technique, I'm completely comfortable providing the therapy they need.
Good. Great stuff.